Welcome back. So we are starting now the second half of this conference, and in fact we're first going to start with the last of the health sessions, and right after that we will jump to climate and then quantum technologies. So a nice bouquet of topics, all following the same red thread, which is compete or cooperate. What is the new normal for global R&D? So staying on health a little longer, COVID, and for obvious reason, COVID-19 has been the center of attention of everyone. Citizens, doctors, politicians, hospitals, and so on and so forth. But it shouldn't make us forget about other diseases. And in fact, in the next 15 minutes, we're going to look beyond COVID and look at where should the world go next. So we're going to look at other diseases that we shouldn't completely ignore right now. And to introduce our next speaker, I'm going to hand over to my colleague Simon Pickard, who will be back with us. Simon is the Network Director at Science Business. Simon, over to you.
Marilyn, thanks very much, and thank you to our audience for rejoining us after the networking break. As Marilyn said, and as we scratch the surface of in our panel session, there are huge pressures on health systems worldwide as a cause of the pandemic, and by extension, worrying trends in other population health domains. So beyond discussing whether or not the lessons learned from COVID can be applied to other parts of the health system, there's an equally relevant question: where should the world act next? So to delve into this, I'm delighted to be joined by our special guest for this fireside chat, Janneke van der Kamp, the head of region Europe for Novartis. So we're delighted to have Janneke with us. Welcome again, Janneke. We hope all is well. It's a very big question to be discussed in a pretty short period of time, but let's crack on with the opening question. Looking beyond COVID, what do you see as the most pressing issue for health leaders to be tackling next, and why?
Yeah, thank you, Simon. And I think the three most pressing issues for healthcare are basically three C's. COVID, as you have already mentioned, cancer, which to a large extent has already been a key priority for Europe with the European Cancer Plan, good priority, good awareness, and cardiovascular disease. The cardiovascular disease, as I'm sure you all know, is by far the biggest killer in Europe. About 4 million people a year in Europe die of cardiovascular disease. But in contrast to the other two, COVID and cancer, it actually hasn't received a lot of policy attention in most countries and also at the European level in recent times. So I would argue that cardiovascular disease is really the one we all collectively need to focus on next, the most pressing need. And I think the good news there is that there is something that we can do about it. It's not like Alzheimer, where yes, we would love to address Alzheimer's disease, but there's very little available that we can do today for patients with Alzheimer's disease. In cardiovascular risk management, we know what we need to do to address cardiovascular risk. There is a lot of interventions, a lot of therapies available. So it's doable. We can actually, if we put our mind to it and our power behind it, we can make a significant dent altogether in how many people die of cardiovascular disease in Europe. So I would vote for that one.
Very good. Okay, so second question. If there are lots of tools available, why are there bottlenecks in the system? What are the current bottlenecks? How could they be most effectively removed, do you think?
Yeah. Now, I really like your bottleneck analogy. Actually, this morning I was taking a train and I thought, this is a real interesting situation where you have a lot of capacity in the train, a lot of people scattered in the station, and then there is this real small funnel, right, the door that you all have to go through to reach this capacity. And I think it's very similar with the healthcare system in cardiovascular disease. There are a lot of tools, interventions available. There are patients, a lot of patients with cardiovascular risk scattered all over the place out there. But somehow, all of these patients are not getting to all of these solutions, or the solutions are not getting to the patients. I think the difference with the train, or one difference between the train and cardiovascular risk, is that with the train, there is a clear pull. People want to get into the train. With cardiovascular disease, many patients are all over the place. and not always well educated or aware of their risk factors. And also the healthcare system doesn't often know where they are. We don't have always the right tools to identify those patients. We don't have the right incentives maybe to bring them into the system. And actually sometimes there's a disincentive of using innovative therapies to treat those patients properly. There might be paperwork involved to get patients to goal. So those are a few of the bottlenecks that exist that prevent us today from treating cardiovascular disease properly. But again, I think I'm an optimist, I'm a positive thinker, and I would argue that all of these, although not not easy, but all of these bottlenecks are somehow under our control. If we put our collective energy and mind towards this biggest killer in Europe, imagine what we could do. Right, this is the biggest killer in Europe. Imagine if we could only reduce the number of deaths by 25%. That would be 1 million deaths that we prevent. On top of that, we would really reduce inequalities, because there's a big inequality component to cardiovascular risk, as I'm sure you're all familiar with. And we could actually free up a lot of hospital capacity, something we're all struggling with these days. We could free up hospital capacity, we could reduce cost. If only we would form, the right public-private partnerships is, I think, where the solution direction is to address all these bottlenecks that we have.
Well, in the context of the partnerships, Janneke, I mean, we talked about that in our preceding panel about health technology ownership and capacity building. I mean, Novartis announced a pretty impressive partnership last week, I think, with NHS England about accelerating the access to innovative CVD treatments for patients. I mean, what's the key takeaways from this partnership model, and where do we go with that kind of insight, do you think?
Yeah. So yes, indeed, a very exciting moment last week when every key stakeholder in the NHS, as well as Boris Johnson himself, publicly talked about how excited they were about this partnership to specifically reduce ASCVD, so lipid lowering is the main objective of this partnership. And just a bit of history of where this came from. So about 2 years ago, the NHS on the one hand made it very clear, it was very clear for them that cardiovascular risk was the one factor that they should address to significantly impact the health of their population. It was very clear to them that this is the disease area where they can really have a significant impact. So high on the agenda at the NHS. At the same time, we were in the process of filing and registering inclisiran, an innovative small interfering RNA lipid-lowering drug that basically cuts the LDL levels in half. But not only that, it's also convenient. It has to be administered only 2 times a year. So the NHS had the ambition to make a big difference in cardiovascular disease and preventing mortality. And we had this ambition to, bring this novel medicine to many patients fast, because our frustration often with launching cardiovascular medicines is that it takes such a long time to reach a significant patient population. Again, this bottleneck situation. So we started to discuss with them on how these goals, their goal and our goal, were actually pretty well aligned, and how we could together really make a difference here. So we started working on how do we identify the patients, how do we treat them properly, how do we monitor them, how do we measure the outcomes. And this work together has been going on for about 1.5 years now, to culminate indeed in the launch of this public-private partnership publicly last week. And we have clear, ambitious goals. We want to treat 300,000 patients over the next 3 years, prevent 30,000 deaths and 55,000 strokes and heart attacks. So yes, it is a prime example of the type of partnership that I believe can really work, can really make a dent in cardiovascular risk and really reduce mortality and reduce all those consequences. Well, so exciting times for us, and again, I hope that we'll be able to form similar partnerships in many other countries.
So there's a related question to that, Janneke. I mean, it's great for England, but is it realistic that this kind of model will be adopted in other health systems in Europe or beyond? Are they ready for it?
So, great question. The conversations we've started to have, many of them are actually very positive because, like the NHS, many healthcare policymakers do realize that cardiovascular risk is their biggest killer. It's the same in every country. So if they have time to think beyond COVID, and they will see this as a real opportunity for them to make a difference. So there's open doors. But then, of course, how that partnership works will be different in every country because obviously healthcare systems are different across different countries. I think what is important for any partnership to be successful, and this was confirmed in a recent Harvard Business Review as well, is there needs to be value alignment, right? It needs to be a win-win situation. It cannot be one party wins, one party loses. Both parties need to gain, otherwise the partnership will not be sustainable. And yes, there needs to be trust and respect and transparency of objectives. And yes, we are a pharmaceutical company with objectives around patient access, but also, of course, commercial objectives. And we're not shying away from that, right? There is something in this for us as well, both from a purpose perspective, as in, we feel much better if our medicines reach a lot of more patients in need than if that goes very slowly. But also it needs to make business sense for us, right? And one of the ways in which such a collaboration can make business sense for us is in the price-volume equation. So if we can reach a lot more patients faster, and if the healthcare system, like the NHS is going to do, is really putting their capabilities to bear to educate HCPs, educate patients, put the right incentives in place, then we need to do a lot less effort on that side and can also therefore offer much more attractive prices. So it is clearly a win-win situation that we're striving for, and I'm convinced it's possible in other countries, but it will look different because healthcare systems differ.
Absolutely. I think the business case question is a really important one. I mean, I guess in terms of the sort of the economic incentives and this value alignment, does that actually roll over into R&D strategy as well? I mean, it must be a way of trying to balance the commercial incentives and perspectives with what you're doing in the science and technology, what you're doing in the laboratories, and where you see the long-term priorities in policy and health systems. Is that the kind of discussion that you're having internally at the moment about how to align the two?
Yes, there's also part of that because, we all know that, again, cardiovascular disease is a big killer, but we also know that for pharma companies to actually innovate in this space tends to be very costly because you need to do very long studies with a lot of patients to prove the long-term outcomes. And that's investment is only feasible if you know that at the end of it, right, there is also a good uptake. And in the past we have seen sometimes a pretty disappointing uptake, as I described before. It takes very long for any drug to get used by a big amount of patients, and therefore the commercial equation doesn't really work out that well in these types of disease areas. But if we can pull this off, if we can launch in a different way, bring a medicine to a lot more patients faster, there's a win for us as a company, and there's a clear win for the healthcare system, as we talked about, in terms of saving lives, in terms of freeing up hospital capacity, saving costs, reducing costs, and addressing inequality as well.
Fantastic. So, Janneke, thank you for that. There's one last question in the last minute or so that we have remaining, and it's probably the hardest one. What does this take to move forward? How do you see the agenda progressing? Is it policy leadership at European level? Is it more industry-led dialogue? How do we get that third C, for example, into the broader set of long-term priorities for health systems in Europe?
Yeah, no, absolutely. I think everything starts with political will and prioritization. That's how the collaboration with the NHS starting, with them realizing this is our priority, this is what we need to do something about. So, and there's some policy alignment already. You have the WHO with their 25x25 plan, where they say we want to reduce the amount of cardiovascular deaths by 25% in 2025. So that's one great statement. But my call to everybody here is that we need something similar to the cancer plan, which really creates awareness, prioritization. We need that at both a European level as well as at a local level. We need a cardiovascular disease plan, and we need it urgently. And in that way, we can altogether have a massive impact on mortality, on hospital capacity, on cost of the healthcare system in the coming years. So that will be my big ask. Let's take this biggest killer in Europe seriously and make sure we have a good plan at European level and at local level to address this biggest killer.
Fantastic. Well, that's a clarion call to action. We always love having those in the Science Business conferences, and we'll be sure to follow this as a theme in the months ahead. But Janneke, thank you very much for taking the time to join us today and for bringing our health block to an end. And with that, I'm now going to hand back over to Marleen Fiaski, our Chief Executive, to transition us to the remainder of the conference programme.